seeing patients waiting in pain, with disability, unable to work or participate in their family lives.
None of us are under any illusions about the pressure on our hospital system.
Healthcare in Australia is a highly politicised topic, largely due to its complex funding structure. It is a system that is supported by federal and state governments, private health insurance, and of course, out-of-pocket payments. And during a cost of living crisis, this leads to ongoing debates about who pays for what and when. Debates that not only divide political parties, but play significant roles in election campaigns, but also divide healthcare providers and patients ourselves. At the heart of these discussions is Australia's universal healthcare system, Medicare, and is based in issues surrounding its funding, its scope of services, its affordability for both governments and citizens. Another layer of complexity is the division of funding responsibilities between the federal and state or territory governments. Beyond the political parties, advocacy groups, including medical associations and patient advocacy groups, play a significant role in shaping the political debate on healthcare. And so joining me for a check-up on this complex Australian healthcare system in 2025 is our Senior Associate and Healthcare Sector Leader here at Banksia, Kushan. Thank you for joining me today for a Cuppa of Thoughts on healthcare in Australia.
Good to be here, Gordo. Thanks for having me.
So first question, and one without notice, as I always like to start, is why is healthcare politicised in Australia in particular, given that, the WHO and the United Nations have all agreed that it should be a universal human right?
What it comes down to is essentially, and I know it's said over and over again by politicians, but it comes down to how much money we're going to put into healthcare and to what programs, and then the squabbling over money, over who's responsible for what. It becomes political when it becomes a question of money. And as you know, the question of money is really, it's just the haves and have-nots. If you take Victoria and Australia, for example, there's a lot of people who have access to private healthcare and have access to private hospitals, and many choose their own surgeons and their own ophthalmologists and access to who gives them care. But a lot of people don't have that choice. So I think that's when the squabbling needs to sort of come down to, well, what are we actually here for? And the answer to that is we're here to get better health outcomes for every Australian, no matter where they live. And there should be a better understanding of, well, what's our roles and responsibilities here? Where are the opportunities for reform? And that's where states have come together to discuss the National Health Reform Agreement, which is expiring this year, and to look at, well, how can we boost access to primary care and community health, and how do we support some of those preventative care measures to take pressures off the health system? The inequities in accessing healthcare leads to broader problems. It limits people from working. It limits people from living a life that is productive and happy. So it is a question of money, but then it's a really question of, well, how much do we want to invest in this for our future and our future generations, so we're not actually placing longer term strain on our system?
I find it interesting, and maybe this analogy is too crude, but something that is, like you just said, like we all experience healthcare, yet it is seen something that where, it gets almost lumped in as a choice or a consumer product. So that's why the discrepancy between private and public healthcare is I want to have choice. I should be allowed to choose these things. I don't just want to have what is provided to me by the government. And there's a debate we can have about the place of private healthcare and private health insurance in the scheme and in the mix. But when I go back to the politicisation of this, is that I feel like the funding and the money spent on healthcare is more political than, say, infrastructure and roads. When a road gets built in a rural town, it doesn't only help that rural town, but it predominantly helps that rural town. But I pay for it as a person living in a metropolitan area because it comes out of my taxes.
Yeah.
I don't get to choose where that road is built. I don't get to choose who drives on it. I don't get to choose who builds it. The road just gets built and it comes out of my taxes.
Yeah.
But when we go to healthcare, it's like, well, why should people who smoke get access to the public healthcare system because that's their fault? Well, the same could have been said for this road. Like, why do you live in this country town? And then the reality is that in healthcare, it's the same thing. Well, they don't always choose to live there. Like, situations happen to humans. There is chance, there's random, these things happen. And then we kind of let that road be built. But when it comes to healthcare, the politicisation seems that the model is focused on me as the individual, and then therefore it's up to each individual to own their own health, whether that's via money, whether it's via commitment to living the right lifestyle or whatever that is. Is there a way that we can change through communication a healthcare model that is focused on a person or patient-centric, which has its benefits definitely, especially when you're being taught how to be a medical professional. Patient-centered care is very important. When it comes to programs, is there not a benefit where it's more about the program itself and like the collective use of resources for everybody regardless of their situation?
Touch on your point about the programs, because that's where, you know, your community health programs and your services actually come into it, because you can assess and evaluate the success of a program over a number of years, but it's not necessarily easy to do that when you're providing care for different people with different health needs, right? And I think that's when the sort of challenges come. But overall, you can sort of access the sort of information that you can gain from, for example, an after-hours mental health clinic and go, well, what are the outcomes of, you know, these patients or these people that we saw? And you can even look at their healthcare, you know, pathway or their journey. You know, did this prevent them going into more of an acute mental health service? Were we able to manage them through a counselling service and other sort of wraparound care? So there's all those sort of elements that come into it. And yes, you can absolutely assess it, but I think there needs to be that starting point of which I don't think we do as often in the primary care setting, is really sort of actively manage someone's healthcare needs and enable better health literacy as well, and helping someone access that care and helping them stay on that pathway and supporting them to stay on that pathway for long term.
And I think there's also an interesting communication to be had with the general population around what healthcare can be seen as and why government should invest in earlier interventions. And even that language is probably restrictive. And I know that from going through the teaching process, it's like a lot of the system is set up to that you get sick and then you get better. But we know that the most efficient way to provide like globalized healthcare is that you don't get sick in the first place, not because you're perfect, not because nothing wrong happened to you, but because, like you said, you're literate to what's available to you, but also it becomes like you're not to blame as a person for feeling ill, mentally unwell, overweight, whatever it is. Just that if you need help with your health situation, whatever that is, that the right thing to do and the encouraged thing to do is to go and see someone about it. And I think at the moment, because we see it as a cost thing, individuals think often that like, oh, it's not worth it. I'm not going to go to the doctor because it's not worth it because I have to use time, I have to use money, I have to use resources getting there and getting back. And then I'll go there and I'll be like, oh, you're not even that sick, it's okay. Whereas the situation has to change to a way where the model is allowing people to have health conversations with health professionals that say, it's really good you came and saw me this early. So now we can teach you, we can get you in contact with people, we can get you in contact with services and educate you and like, yes, when you're feeling like this is what you do. And then hopefully in the future you do some other things to prevent you from feeling even like this and you'll feel better and better. And I think that's the communication not only to patients but also to governments and providers that needs to happen, that this system is not a transactional, I'm feeling X so Y needs to happen. It is you are in charge of your own individual health, but everyone is here to help support you.
Asked if more than 20 regional hospitals had been ordered to slash their budgets.
Right now we are negotiating the budgets for our individual health services. Some health services will see a reduction in their funding, but most will receive an increase.
When asked why,
it's really important that as we come out of the period of COVID emergency, that we work to rebase the way in which we fund our hospitals.
So one of the biggest, I suppose, diversities of appetite I see from governments from reading budgets, both at federal and state level, is healthcare gets spooked a lot in infrastructure. And they love to say, we're going to build a hospital, we're going to build some infrastructure, we're going to build buildings, we're going to build things. And then we're going to trim down the services of everything else. Do you have any insight as to why that is the case? Why is a big, and usually there's large sums of money spent on buildings or infrastructure or tangible things more palatable in a budget than increasing the funding spent on Medicare, for instance?
Yeah, absolutely. I think that's a really interesting point. Governments love to build things. We all know that because it's sexy. You get a good press release up, you can see the building come up, people can see it, and you see the progress of it, and it's a really great announcement. And it's a symbol, like a hospital is a symbol of access to healthcare. And in any announcement, you'll hear it's a multi-million-dollar project, and it'll allow double the capacity of access to care. And you make a really interesting point about the access to services, because I think government want to fund more services, but there's an element of where do we prioritize it, and that's been the sort of confusion, because the federal government is responsible for primary care and having GPs and bulk billing. And where you get a limitation on that side of things, on the primary care side of things, and people cannot access that care closer to home and for free, then you get a whole group of people who may wait to access care, or they put off accessing care. And then what you have are more complex conditions and people presenting at emergency departments with more chronic disease. And then that's what drives up the cost of your health services and the cost of providing care, which is what our hospitals have struggled with. And if you get a large enough of the population doing that, then you've got a massive problem in terms of demand. So you can build as many hospitals as you want and have as many beds, but if you're not actually addressing the key issues, which is preventative care and ensuring that people can access care at the right time when they need it, you're not really part of the solution.
And so then how would you suggest that organisations who have a primary and preventative care approach make it sexy for governments? How can, if you want to have a submission that goes to government, what can you do to create that symbol that shows that, like, yes, it's not a hospital, but actually our program helped keep 25,000 people out of hospital. They don't even need to go there in the first place because they have, the connections, they have the intercommunity supports that they have in their actual locales. We don't have to bring them to the city or to a big hospital.
I think community health services do a great job already. I think they need additional funding to support that. And I think when we're talking about funding, I think the Commonwealth government need to look at the community health model and look at the National Health Reform Agreement that they're looking at right now, that they're negotiating with the states, and go, well, what are the opportunities for reform and what are the opportunities of where we have existing services that deliver primary care? How do we emphasize that and boost that and educate people on where to access care at the right time, at the right place, so they're not then waiting and then going to an emergency department?
Part of that then creates a bit of a complex stakeholder issue, not only for patients accessing care, but also the health practitioners who provide care. The preached gold standard was that you'd have a central general practitioner for each and every patient. That'd ideally be a lifelong connection, and then they would help facilitate and take you on the journey of allied health. So I come in, I haven't seen you in 6 months, what's been going on? Oh, okay, you might need to see a physio or a chiropractor or a dietitian, whoever it is. That system doesn't seem to work now that we have more transient people. We have people not living in the same locales and changing lifestyles. And obviously the cost of living, mass bulk billing is no longer happening. So it's deteriorating that relationship between patient and general practitioner. And one of the suggested outcomes in that, under that right care, right place, right time model is, well, other allied health professionals are getting better and more skilled at diagnosing and treating plans, at prescribing interdisciplinary plans as well. How do you rebalance that significant change in the model that suits patients without disrupting the interrelations between the rest of the medical stakeholders involved?
Yeah, and I think it starts with, and the federal government's already thought a lot about it and has announced the Medicare reform package. So I think it starts with access to GPs, right? And then your GP should be your central point. And then they should then integrate with other allied health professionals and other care providers that you need. But that necessarily shouldn't disrupt the current sort of status of things. I think the current status is, to be honest, really fragmented, because some people might know where to access that care, but others may not. So it creates this inconsistency, and it goes back to my earlier point around, equity and what services you may get in, for example, regional Victoria might be very different again in metro. And so often there's critical gaps in regional Victoria where there's not enough GPs. There's the tyranny of distance as well, where, people have to travel long distances to get the care that they need, and sometimes they don't, and they have poorer health outcomes because of that issue. So it's the Medicare reforms. Getting more GPs into regional areas is critical, and I know there's sort of incentivized programs to get them there, but those are sort of long and short-term challenges of it. I know the Victorian government stepped into this space recently and announced scholarships and bonuses for GPs who are training in that space, for doctors who would want to practice in general practice. But I think more needs to be done by the Commonwealth government to really boost that. And there could be, they're looking at international recruitment campaigns, and they did that successfully for nurses and midwives. But those are the elements, because it was ignored for far too long over the last decade. The pandemic really highlighted some of those gaps and really showed us that, this is a serious problem.
To touch on that then, you're talking about post-pandemic healthcare. I think one of the most interesting changes is this decentralisation and decentralised models, whether it be digital or other forms. Because again, the central approach is not only just in terms of like face-to-face interaction with doctors, but also hospital to patient interaction with doctors. When you're training from, third year onwards, you're in hospitals, and then you do some rotations to a GP. But your predominant place of work and training is a hospital. And then I think it kind of reinforces the fact that like, this is what being a medical professional or a doctor, I suppose, in this case is. Is there a way that we can actually approach it, say like being a doctor doesn't have to look like that? Being a medical professional doesn't have to involve the hospital at all? Because, if I live in regional Tasmania, remote Western Australia, yes, it's a smaller proportion of our population, but the population is still significant. They're not going to have a hospital in a town that only has 300 people ever. How do we start to change those concepts of thinking that like this is medical care, this is what it looks like, we need to build a hospital to make an announcement sexy? Like how do we start picking apart these kind of myths of healthcare?
I think it's starting that conversation early. What's preventing you from starting a general practice clinic, or what's preventing you from going down that road versus the other? So it's understanding their barriers, and there's various colleges. There's the Royal Australian College of GPs that would have some really great insights into that. And even health leaders and health sector leaders would really be able to understand and inform us around, well, what are these students looking for? How are they looking to progress their careers? And how do we support them to do that? And how do we support them to get into this space?
So as you mentioned there, dollars is usually the answer or the reason behind a lot of these barriers or blockages in the system. And one of the biggest blowbacks to health spending just seems to be, this government is being fiscally irresponsible. Part of me never likes that answer, because one of the roles of government, from my point of view, as more of a citizen, is, well, that's why governments are there. Big government is good in the sense that it's meant to provide me universal healthcare. So really it shouldn't matter how much it costs. It should just be, can we execute this need? Why is this the line that's always brought out? And then I suppose, how do advocacy groups get around it in terms of like our debate currently around GPs is that, Medicare doesn't have the money currently to bulk bill everyone. How do we change that discussion, and how we show that it is possible?
It is possible. I guess it comes down to a couple of things. And if I take the Victorian example again, I mean, we've got one of the best health systems in the country, if not the best, on various metrics. And Australia as a whole is one of the best healthcare systems in the world. So I think it comes down to, when it comes to Victoria in particular, whether the spending on health, like we spend billions, it's multi-billion, and whether that's sustainable, and whether we need to look at more sustainable models of care to get the same health outcomes or better health outcomes. And if I think about the pandemic and how awful it was, despite all that, it was still a catalyst for reform. And it really got our health system thinking about, well, how can we do things better? For example, planned surgery was a key example of that, because they paused planned surgery during the pandemic to focus on the emergency response. And so once we got out of the emergency response, the state was left with a public health wait list for planned surgery, almost 90,000. And that means, again, poorer health outcomes. People are waiting in pain. It's impacting their mental health. It's impacting their ability to work. The health system was actually pushed into this space of reform and thinking about new ways to do things. And we saw hospitals and clinicians come together and go, well, we can actually do a knee surgery, in a day and send someone home. We can educate people better to prepare for surgery, so we can do the same day surgery and then send them home and then help them recover at home. And those home-based models of care were really emphasized and really supported. So you'd sort of structure your care around getting your surgery and then, linking back with your GP around follow-up care. You'd laugh at this, Cora, but hospitals created hit lists to bring down the wait list. And you look concerned, but hit lists aren't what you think they are. They are what we call high-intensity theatre lists. And the purpose of them was to do a single procedure. So to prep a theatre, and you prep the surgeons and you go, we're doing hip replacements for the next 8 hours. And that had an immense impact on the wait list because you just had reductions in those particular procedures. And it was when hospitals and surgeons decided that, yeah, we're going to do this and we're just going to, channel them through. So those types of reforms were unheard of before, or had not been as regularly done. And it showed it worked because Victoria, I think in the last financial year, delivered almost 210,000 planned surgeries, which has never been done before. So you could see how, those reforms put into place worked, and they can now build on that, and it ensures people actually get treatment at the right time.
And so around those efficiencies, it creates, I suppose, again, a different focus on the model. Obviously, we want to be more efficient. We want to use our resources appropriately. But then how do we balance that if that's the expectation of a healthcare system, which becomes very transactional and I suppose mechanical, with a system that also allows that human and interpersonal connection? Because I think that's where the complexities around Medicare and bulk billing and having a primary point in primary care becomes difficult to correlate to the rest of the system, where one system is focused on efficiency. We did 210,000 operations. How efficient is that? Versus a GP that's seeing 30 patients a day when we don't want them to see 30 patients a day. We want there to be more GPs so they can see fewer patients but for longer.
I think that's what comes back to how do we support primary care and community health, right? Because we don't want people to go into surgery when they don't need to. So it's that education element of it that is, I think, really missing here. And the health literacy for the community is something, there's a real piece of work there for governments to inform public opinion there, because that's the key part that's missing. Because again, it comes down to people not understanding where they can access care, which then leads to people, calling an ambulance when they don't need to. And then it leads to sort of ramping or them waiting long hours in an ED because they're actually not meant to be there, but they actually have nowhere else to access that care.
So we spoke a lot on Victoria. You have experience in the state government, and we obviously live in Melbourne, so it makes sense to have those discussions. But how many of these issues and solutions are replicable in other states and in non-metro environments as well?
I think they're all applicable, but you need governments to make a decision and you need clinicians to be on board. And I think the latter always is. I think clinicians and, doctors and nurses are always there to innovate, and they're always looking at the best interest of their patients. So I think at a hospital and a healthcare level, there's that element. I think you just need governments to sort of back some of those changes in and help them educate the community there, because that is the important piece. It's around education, and that takes sometimes a slower pace, and we're getting there, but it takes a slower pace than getting people on board who are actually who understand the sector and understand medicine.
And then how do we tie those two things together then? It seems like the medical field has no shortage of innovative solutions and ideas for how they could fund them, and governments need to have solutions to these problems. How do we as communicators at this firm help those organisations then? What is the missing piece that you currently see in how industry and the medical industry communicate with government when it comes to trying to convince them to fund these initiatives, whether it's something big like the blueprint for planned surgeries, or it's something more broad and long-term like health literacy?
We have a number of medical colleges, number of health organisations and peak bodies that actually do a really excellent job in advocating to the department and to government, to various ministers. It can be a challenge because it's such a big network. And, if you think about Victoria, we've got 76 health services, which we need hospitals and health services to work better in partnerships. And, having 76, which is more than the rest of the country, it's just not a system that I see that works. So it's really about bringing sector leaders together, hospital leaders together to say, well, how do we work better? And those are sort of the conversations I think that a lot of peak bodies are having. How do we engage with governments, and how do we align with their priorities? Those are sort of the key questions. So working alongside various state governments and understanding, well, here are the gaps, and how can we support you to achieve your priorities here? And that could be strengthening partnerships between health services, and how do you do that? and what are the benefits there, rather than, building a brand new hospital and then having that sort of be at capacity at, a decade's time. How do we ensure that people are getting that access closer because the sector has decided that it can work together better?
Awesome. Well, that kind of brings us to a natural end to this conversation. But for the health nerds out there, rejoice, because this will be an ongoing series that we'll have throughout the year. And hopefully we'll be talking to some of those people that may have the actual answers to some of our questions that we've risen today about how do we strengthen partnerships, how do we lobby to government, and how do we solve a complex problem that is the public healthcare system. But for today, thank you for joining me for the Cuppa of Thoughts, Kushan, and until next time.
Thanks, mate.